Good morning, dear friends, ladies and gentlemen, colleagues that are united today in the prestigious occasion of the World Congress of Gastric Cancer. Let me thank you again with my heart for the kind invitation on behalf of the European Society of Surgical Oncology to address to you today with some updates from what has recently been addressed in Europe regarding research in treatment of gastric cancer. I will briefly talk about what is going on, especially with regards to European studies, both in medical oncology and surgical oncology. And first of all, I would like to talk about what is coming from the so-called big data. I'm using this expression so-called because population big data is still to come. But since in Europe and in other countries, there have been a lot of trials accumulating interesting population data of patients that underwent trials, we have now the possibility of looking back to these numbers and try some new conclusions. These are patients reunited from mainly British studies, but of course, these are patients selected for trials. What has come out from this study is something apparently a little bit futile, meaning that female have major chances of survival even if they experience some more toxicity from chemotherapy. I mean, this is not what we really need. What is interesting with the same methodology of looking back to data that were preserved from, in this case, the MAGIC trials, these patient data, specimens were re-examined by nanostring, and nanostring looking at a group of genes that are usually associated with some risk of gastric cancer, were able to separate two classes of patients based on their genetic signature, whose prognosis is totally different. So we are envisaging a future where the previous genetic classification that was issued in 2014 and which didn't give so many clinical fallbacks now is a little bit estimated by the knowledge that gastric cancer is a very heterogeneous disease, both from the molecular and the genetic point of view. Data coming from Europe also demonstrated that what was once one of the truth coming from the United States with the McDonald trial are not really what we need. This is the demonstration that radiation therapy administered post-operatively in patients who underwent quality-controlled radical surgery plus chemotherapeutic regimens that at that time were already implemented by epirubicin and platin, in this kind of treatments, in perioperative, modern treatment, the adding of radiation therapy has no value. And this is, an interesting conclusive data coming from the famous critics trial. More from Europe again, we know since some years from a cooperative study coming from an Italian first researcher that patients enrolled in different trials showed unequivocally the fact that microinstability as a biomarker was a terrible indicator for bad response. And this is well known, and some patients now are totally excluded by neoadjuvant treatment protocols just because they show microinstability. What are we doing in Italy at present is trying to reassign this patient to a neoadjuvant experimental treatment based upon immunotherapy, addressing two immune checkpoints, trying to reach the same incredible results that by the same methodology we have observed in lung cancer. This is an ongoing study, the Infinity study, and we will soon know something about this. Another important breakthrough coming from Europe was the FLOT study. ECF, epirubicin plus platinum-based therapies have been totally replaced at least in Europe, by a 4-drug regimen where oxaliplatin is coupled with taxanes. And, incredible effect of FLOT in a few years have made the fact that this is the new standard. Of course, this is not all. What is interesting, on the base of FLOT, Ramses study is trying to add an anti-angiogenic antibody to the FLOT efficacy. And we are looking forward to look what results this kind of approach can give to us in the next couple of years. Another interesting study, well knowing that HER2 patients show a very sensible response to trastuzumab, is adding both in pre-op and post-op treatment trastuzumab to FLOT. This is the Petrarca study design. This is a randomized multicenter investigator-initiated phase 3 trial. These conclusions have shown that the addition of trastuzumab in perioperative schedule significantly improved pathologic complete response of these patients. And this was so evident and strong that now the innovation study has coupled interest from the Netherlands and Korea together to add trastuzumab in neoadjuvant scheme, both to FLOT or to another kind of regimen that is, mainly capox. That is what it is administered in Korea. Trastuzumab and pertuzumab in these peculiar innovation studies are the two immunoantibodies that have been added. And then still we observe a lot of patients that after resection has a very tabular prognosis based upon the extension of lymph nodal disease, or also on the fact that we cannot define as R0 the operation that has been accomplished. So in this kind of high-risk patient, there is a new study coming from EORTC, the European Organization of Trials in Europe. That's called the VESTIGE study. It's a still active study that is still recruiting, where nivolumab and ipilimumab, again, checkpoint inhibitors, are added to an ordinary post-op chemo in order to show if there is any results with a primary endpoint, that is the disease-free survival of these high-risk patients. Claudin, it's another molecular target that divides patient prognosis in different classes. Now we have a monoclonal antibody that is expressly directed towards Claudin, the zolbetuximab. And this is a German study trying to understand if it is true that different kind of Claudin expression correspond to a very different prognosis when this kind of zolbetuximab is added to ordinary post-op chemotherapy. We will see if these results will be confirmed by larger trials in the next future. But let me talk a little bit also about surgical oncology. And the summary of the topics that I will talk about are optimizing surgical treatment to reduce morbidity, optimizing our treatment for elderly patients, quality and health management, and advanced disease. Just to see and to let you know that a lot of this interesting study come from the Netherlands, a country where there is a very good propensity towards investigational studies. Tentacle is focusing on the definition, classification, and trying to understand how we can control the dreadful complication of this surgery. This is totally addressed to the esophageal anastomosis. Of course, gastrectomies are included, but this is a very peculiar study based upon monitoring of complication. But again, from the Netherlands, we have had this important study called Logica trial. And Logica trial is demonstrating also in Western countries, after the demonstration that we received from Korea and Japan, that even in locally advanced tumor, laparoscopic gastrectomy has a total non-inferiority with regards to conventional open gastrectomy. This is a control trial that was based upon high quality surgery made in the Netherlands. These are some results from my group, just showing that 30% of the patients that we treat nowadays are elderly patients. And if you look at this world map, there is high concentration of studies on elderly patients and high complexity surgery in Europe, where we probably observe the maximum concentration of elderly cases in high complexity surgery. And this is an ESSO study, a study of my society that is called the Go Safe, that prospectively collected a baseline multidimensional evaluation before major elective surgery in elderly patients. And looking at these data, you will note that this patient at a median age of 78 years with a maximum 94, they lived at home 99% of the cases without a caregiver, half of them, and half of them needed more than 3 medications a day. All of them, of course, had major comorbidities, at least 1 out of 3, and 1 out of 5 had mild cognitive impairment. So this is a very fragile population, but we are operating every day more patients belonging to this age group. So it is time to have a very well-organized pre-op, intra-op, and post-op pathway in order to reach at least the same outcome in patients that deserve the same attention of any other patient, since our population is getting older and older. This is another European study. And of course, in Europe, there is a very high attention on how to concentrate high complexity surgery, and the esophagogastric surgery, of course, belong to this specific group of surgery, in high volume center in order to respect the proportion that we have between volumes and outcomes. Scandinavian countries, Netherlands, maybe Britain have adopted such a kind of concentration from years, but now it's going on and it's moving towards Southern European countries. There are experiences in Spain as well. So concentration is a must, and this is a study of mine in order to press on behalf of the European Society and the Italian Society of Surgical Oncology, the Italian government, to concentrate. And if we look at the different counties in Italy, we have the possibility, even if gastric cancer is not so predominant disease, to concentrate at least 25 cases a year minimum in most of Italian counties, meaning that patients should not need to travel long distances to be treated in hospitals that have an acceptable volume. But if this is a possible result, making the outcomes in parallel totally different from what we observe now, even in those counties that nowadays already have this kind of concentration, the results are not well distributed. So skill and volumes not always are perfectly corresponding. And this is something that we should talk about before giving to the politician the decision on how to treat patients. So improving competencies and skill is our task for the next future, especially for high complexity surgery of non-frequent diseases. Nutrition. This is another important point in order to rehabilitate patients that are not only fragile, not only old, not only concentrated in diverse areas, but affected by gastrointestinal cancer. Most of them have a bad nutritional status at the beginning of their treatment pathway. And we are inserting, as a group that I am coordinated in an Italian study, this patient in what we call acyclic diagram, in order to weight the importance that nutritional support has in all the disciplinary factors that are influencing postoperative morbidity and length of stay in hospital and complication rate of this patient. We strongly believe that nutritional support in the 3 phases of pre, intra and post-op treatment can have a strong association with not only decreasing complication rate, but also survival. We will see, and another next frontier coming from Europe are treatment opportunities in stage 4 disease, oligometastatic stage and peritoneal carcinomatosis. Definitions of oligometastasis are important. And what can we do? What are the limits of treatment or control or palliation for peritoneal carcinomatosis? As regards oligometastatic, there is a wonderful project going on all over Europe with the support of the International Gastric Cancer Association European chapter, EORTC, European Society of Medical Oncology, European Society of Surgical Oncology, European Society of Radiation Oncology and Diseases of the Esophagus. All together, representatives of these societies have led a multidisciplinary European consensus on the definition and possible treatment of this subgroup of patients. And we are very far advanced in this process. Some definitions have been drawn, and the first paper has just been published a few days ago. I'm sure that a lot of friends of mine that are attending the Congress will talk to you directly about this. And another important thing is peritoneal carcinomatosis. Of course, we have some data regarding the potentiality of HIPEC in treating and controlling peritoneal carcinomatosis, but every single study shows the weakness of this treatment with intent of cure. There are subgroup of diseases like, poorly cohesive tumors that are very poorly sensitive. And the benefit that are not so high are concentrated in patients that have a low peritoneal cancer index. Whenever a patient belongs to a group like poorly cohesive cancer with a low prognosis, this PCI should be even lower than 13, but just below 7 before attempting with some hopes treatment of peritoneal carcinomatosis from gastric cancer. What is more interesting is the new evidences, and this is an international study with a lot of interest in Italy regarding palliation using PIPAC. So pressurized intraperitoneal aerosol chemo to palliate ascites in this kind of patient that have a terrible quality of life. But more than palliation, we are interested in prophylaxis. There are patients that show prognostic indexes that are, very likely foreseeing the occur of peritoneal carcinomatosis in their future. And these are the patients that are selected in the Gastric study that is mainly Italian-French study. And this is an Italian study that has a similar base, the GOET study. It's a randomized control study going on for, prophylactic HIPEC and limited peritonectomy, including the great aeromentum, the round ligament, the ovaries, and some surfaces of the peritoneum, just to pre-treat patient undergoing HIPEC without having any sign of peritoneal carcinomatosis at time of treatment, but just high risk. This is a summary of what is the news in European research on gastric cancer, but much more you will hear from us if you join in Bordeaux the ESSO 41 Congress that is going to be held on the next October. Don't forget to send your abstract. The deadline is May 31. And with this said, I thank you very much for your kind attention. Hoping to see you personally very soon. Have a good day.